All right, guys. Good evening. I hope everybody is so. Welcome to another series of VLS. We've been discussing about hernia. The last time I spoke about how is the mesh being placed and what are its components, right? So today we'll be talking about one of the most important aspects, which is often neglected during your postings or during when you're reading about hernias. It's about the repair techniques. What are the various surgeries? What are the names of the various surgeries, and how do we go about it? Right. So today's focus is going to be entirely on to be the hernia surgery. Right. So this is like a master class, right? If you are an undergraduate, if you are an intern, if you are a resident, right? This particular series or this particular episode of BLS is going to be absolutely important and useful for you. So do not miss out on it. So today I'll be talking about the various techniques of the hernia. So we'll be discussing about all the open techniques because lap is already discussed. So I'll just go into the open repairs. When you talk about the open repairs, I will be talking about two components. One is going to be a pure tissue repair, and another one is going to be, we talk about one that is going to be a pure tissue repair, another one is going to be the mesh repair. So we'll be talking about the tissue repair. One will be a tissue repair, another one is going to be your mesh repair. Tissue repair is what we call it as the herniorrhaphy. Mesh repair is what we call it as hernioplasty. The word plasty denotes that we are using a prosthesis there. In this series, we are using mesh, right? So talk about the various properties of mesh and all that is going to be there. But this is going to be the single most important component to differentiate between a tissue repair and a mesh repair. Myself, first year MBBS student, sir, currently learning about what is inguinal hernia, just came by excitement. Hi Shiva. Okay, if you want to know what is an inguinal hernia is like, you need to know what is an inguinal canal is. For that, you have to refer back to our first video of the hernia series and then come across here. Today, we'll talk about the various repairs component, right? So, when you talk about the hernia repairs, the today tissue repairs that we're going to discuss. The tissue repairs that we're going to discuss. Number one, I'll be discussing about a repair which is called as the Shouldice surgery. Quite popular. Then we have the Bassini's repair. Then we have the Bassini repair. Another one that you have is the McVay repair. And our own Mohandas Dasarda's repair, and that is what we call it as the Dasarda's repair. So we'll be discussing four important techniques: Shouldice, Bassini's, McVay, and Dasarda's. In the mesh repair, we'll be talking about the Lichtenstein. We'll talk about the Lichtenstein tension free. Lichtenstein tension free. Talking about the Lichtenstein tension-free mesh, right? So this is the objective that we are going to take care of today. So I'll be discussing each individual of them, and then we'll move as we learn better. So let's understand what is Shouldice surgery. Now, Shouldice is what we call it as a double breasting. You have a two, it's actually a four-layered repair, but they're like, one on top of another. It is called as a double breasting. So I'll be talking about our Shouldice repair. So Shouldice repair can be done for inguinal hernia. It can be done for both direct as well as indirect inguinal hernia. When we talk about the Shouldice repair, this is a four-layered repair. It is a four-layered repair. This is also referred to as the double breasting. It's also called as the double breasting. Let's understand what are we going to do in the Shouldice repair. Now, you remember our own analogy that we had. This is the external oblique aponeurosis that we have already discussed it. So this is the external oblique aponeurosis. This happens to be the superficial spinal ring, and this is the orientation that you have for the external oblique muscle as well. So this is your external oblique aponeurosis. So this is the external oblique aponeurosis that we have already discussed, right? Now, behind the external oblique aponeurosis, you have the internal oblique muscle, then you have the transverse abdominis muscle, and behind the transverse abdominis muscle, you have the fascia transversalis, right? So we're going to cut the chase to that, and we'll move down to the fascia transversalis, right? I want you to be a little bit patient because a lot of concepts and technicalities are going to be here, but I'll try to give you a very easy way to understand. So just be a little bit patient with me, right? So this is your external oblique aponeurosis, and then you have the superficial inguinal ring that is present here. Now, behind the external oblique muscle, what do you have? Behind the external oblique muscle, you have the internal oblique muscle. We are not worried about the internal oblique. So this is the internal oblique muscle that we have. Behind the internal oblique muscle, you have the transverse abdominis. Not worried about the transverse abdominis. And behind the transverse abdominis, you have the fascia transversalis. This is your fascia transversalis, which is going to be through, right? So what we are going to do is, I am going to open the external oblique aponeurosis. So obviously I've opened the skin, I've opened the subcutaneous fat. Now I am left out with external oblique aponeurosis. I hope everybody knows that the condensation of the external oblique aponeurosis on this inferior segment, which is here, which is now becoming like a tuft of band. This is what we call it as the inguinal ligament. This is your inguinal ligament, and that canal is what we call it as the inguinal canal. So what I'm going to do is, I'm going to make a session. I'm going to open up this entire inguinal canal. Now, the minute I open the inguinal canal, so this is how the inguinal canal is going to be opened. Now, I'm going to open up the inguinal canal, right? Now, the minute I open the inguinal canal, this is your external oblique aponeurosis, right? So, the external oblique aponeurosis leaflet is going to be of two forms, right? One which is present on the superior form. This is like you have opened up. This is the superior leaf. This is the inferior leaf. The inguinal ring is gone. So what layer are you going to expose? The minute you do that, I am going to expose the innermost layer which is present. And the innermost layer that you have is your fascia transversalis, and the defect in the fascia transversalis is your deep inguinal ring. So now I have exposed the fascia transversalis and its deep inguinal ring, correct? So I've opened up the external oblique aponeurosis. I have opened up the external oblique aponeurosis. The minute I open, okay. Now, the minute I open the external oblique aponeurosis, I have the fascia transversalis, right? So obviously the hernia, let's say it's an indirect hernia, the hernia is coming from the deep inguinal ring, coming from the, if just for the sake of understanding, if there is a hernia that is arising from the deep inguinal ring, that is indirect inguinal hernia, it will come like this, it will exit from the superficial inguinal ring. This is how the hernia would have passed. What I'll do is, I will reduce the hernia back. I will push it back. Now I have to repair this area. Now the Shouldice repair says, that you have to repair this entire context in toto. So we are going to open up the fascia transversalis also. So I'm going to take it up, and I'm now going to open the fascia transversalis from the deep inguinal ring. So now I open the fascia transversalis. There is a superior leaf of the fascia transversalis. There is an inferior leaf of the fascia transversalis, right? Now once I open it up, now what I'm going to do is, so this is the superior leaf, or I can say this is the superior leaflet. This is the superior leaflet of the fascia transversalis. This happens to be the inferior. This is the inferior leaflet of the fascia transversalis. So what I'll do is, the minute I open this leaflet, I'm going to suture the inferior leaflet to the under surface of the superior leaflet. I'm going to suture the inferior leaflet to the under surface of the superior leaflet so that it strengthens. Once it is done, then I'm going to suture the superior leaflet back on top of here. Sure, the superior leaflet of the fascia transversalis back on top. So there are the two layers that we have repaired. This is the first breasting. I know you're not able to understand this, so I have a small demonstration for you. Now, this is what we have brought it for you. This is your abdominal wall. If you see very carefully, this is your external oblique aponeurosis. You flipped it down. This is your internal oblique muscle. This happens to be your fascia transverse abdominis muscle. This happens to be your fascia transversalis, and behind the fascia transversalis, this happens to be your peritoneum, right? So peritoneum is the innermost layer, and then you have the fascia transversalis. I'll repeat again. This happens to be your external oblique muscle, that is external oblique aponeurosis here. See this opening which is present here, this is your superficial inguinal ring, and from here the inguinal canal starts, right? Now if I remove the external oblique muscle, what do you have inner? You have the internal oblique muscle. If I remove the internal oblique muscle, what do you have? You have the transverse abdominis muscle. If I flip the transverse abdominis muscle up, what do you have? You have the fascia transversalis. Then there's a defect in this fascia transversalis. There's defect in the fascia transversalis is your deep inguinal ring, and you see the internal oblique muscle as well as your transverse abdominis together, they form into a tendon. They are like the fused tendon, and this is what we call it as the conjoined tendon, right? Now this is going to arch on the, whatever the content is going to move inside the, whatever is going to move inside the inguinal canal. Clear? So this is the basic objective that you have for the inguinal canal's anatomy. So this is your superficial inguinal ring. This is the peritoneum. You flip the peritoneum, you have the deep inguinal ring from where the vas deferens is going to enter inside. So one doubt about general surgery, difference between near miss and no harm events. Better that is in the context of OT zones. We'll talk about it. Don't worry. So let's concentrate here. Now I told the Shouldice repair. Right, in the Shouldice repair, you have opened the skin, you have opened the subcutaneous fat. Now you have exposed the external oblique aponeurosis. So what I'm going to do is, I am going to take from the superficial inguinal ring, you can see here, and now I am going to open up the inguinal canal. So this is how I'm opening the inguinal canal, and I'm going to open the inguinal canal through and through, right? So let me do it for you. So we're doing a live demonstration here. I am opening. I've opened the external oblique aponeurosis completely. I've opened the external oblique aponeurosis completely just for the sake of understanding. What I'll do is I'll pin this so that it does not run anywhere. Right. So we open the external oblique aponeurosis. You can see now we are going to flip it up. Right. Now the minute you flip it up, the minute you flip the external oblique aponeurosis up, you have exposed the inner part of the inguinal canal. The inner part of the inguinal canal, the posterior wall is made up of fascia transversalis. There's a deep inguinal ring that is present here, and the cord and the content is here. I have reduced the content. You will have, what do you have from here? So we all know, right? The two structures which are going to move from here. What are those two structures which are going to be present? What are the content of the inguinal canal? The content of the inguinal canal that you will see is going to moving from here. What are these two contents that you have? You will see. Apologies. I want to be a bit more precise, a bit more sophisticated. Kya kare? Okay. The two contents which are moving from here. Now, what are the two contents? One is going to be a vas deferens. Another one is going to be a ilioinguinal nerve. The content of your inguinal canal is going to be your cord, that is your vas deferens, and the ilioinguinal nerve. I'm just going to ignore them because right now they're not important. So we're taking this off, right? Now, whatever content has come from here, I have reduced the content in. Now, in the Shouldice repair, what is the first thing you do? I told that the fascia transversalis has to be divided. So this is your fascia transversalis, this is your deep ring, and I'm going to divide it. So I'm going to cut this fascia transversalis completely, right? So all the way to the deep ring, I'm going to incise the fascia transversalis. As you can see, I'm cutting the fascia transversalis all the way to your deep ring. We'll continue to do so. Done. Bam. Now I have opened the fascia transversalis. You can see here. Okay. Now I can say this is the superior leaflet of the fascia transversalis. This is the inferior leaflet of fascia transversalis. We're going to label that. Okay. We're just going to put small label onto this. We'll say this is the superior leaflet. This happens to be the inferior leaflet. So we have created these two leaflets of the fascia transversalis. One is going to be the superior leaflet, another one is going to be inferior leaflet. That has happened. Now, what I'm going to do is I have to strengthen this posterior wall. I will take the inferior leaflet of the fascia transversalis and I'm going to tuck it behind the superior leaflet. You can see here, I'm going to take behind this and I'm going to suture. So what I'll do is, just for the sake of understanding, okay, let me here. So we have the superior leaflet and the inferior leaflet. We're talking about it. I'm just going to fold these leaflets. I think because I'm resting it pad. Ask the iPad to take a little bit of backseat today. Today is going to be more traditional form of teaching. Right. So what we have done is the superior leaflet that is there, I'm going to fold it up. Right. I'm folding the superior leaflet up. I have folded the superior leaflet up. I'm taking the inferior leaflet and I'm going to suture the inferior leaflet under the surface. So I'm going to suture the inferior leaflet on the under surface of the superior leaflet, and then I will suture the superior leaflet to the inguinal ligament. Okay. So you can see that I've done a double breasting here. So I've taken the inferior part of the fascia transversalis and I've put across here. So I'm going to just staple it so that you understand it better. I've taken the superior leaflet on the under surface of the inferior leaflet, and then I'm going to do a vice versa also. So this is the first breasting that we have done. Okay. Okay. Here we are. So you can see that the inferior leaflet, which is here, I've taken it under surface of the superior leaflet, I've tucked it. I've brought the superior leaflet on the inferior leaflet and I've tucked it. Now this has become solid. It has become breasted, right? So this is what we call it as the first layer of the Shouldice repair. Is everybody clear? आई बात समझ में? तो Shouldice में हमने क्या किया? If you look at the entire story again, the first thing I've done is I've opened the external oblique aponeurosis. After I opened the external oblique aponeurosis, I have the fascia transversalis. I've cut the fascia transversalis. I've created two leaves, the upper leaf and the lower leaf. I've taken the lower leaf and I've tucked it. तो ऐसे दो लीफ बना, ठीक है, अपर लीफ लोअर लीफ. ये जो लोअर लीफ है ना, अपर लीफ के नीचे ले जाके पीछे से सिलाई कर दी, और ये जो अपर लीफ लोअर लीफ के ऊपर आया ना, यहाँ पे सिल दिया. तो अब ये डबल ब्रेस्टिंग हो गया, मतलब एक डबल लेयर्ड स्ट्रक्चर बन गया ना, द डबल लेयर्ड स्ट्रक्चर. This is the first thing that you have done in the Shouldice repair. Now, once you have done this, उसके बाद आप क्या करोगे? You have this conjoint tendon. You see this conjoint tendon? I'll take the conjoint tendon and then I will suture it to the inguinal canal. ठीक है? इस external oblique aponeurosis को पूरा flip कर दो. So this brown one that you have on the bottom is your inguinal ligament. ठीक है? ये conjoint tendon है. हम conjoint tendon को inguinal ligament के साथ suture कर देंगे. ठीक है? So now the third layer that I'm going to put is to suture the conjoint tendon to that of the inguinal ligament, so the floor becomes even stronger. ठीक है? Now you're able to see this floor is becoming even stronger. So now I'm going to take this. So to make you understand, थोड़ा tape लेते हैं, तो चिपका देते. So what we have done is we have taken the conjoint tendon. Conjoint tendon को लिया और inguinal ligament के साथ चिपका दिया. See here? Now we have taken the conjoint tendon and we stick to the inguinal ligament. ठीक है? This is the third layer. The fourth layer is same conjoint tendon and the inguinal ligament. I will take in an interrupted fashion. The first one is a continuous fashion. The fourth one is going to be an interrupted fashion. Finally, I will close the external oblique aponeurosis and your repair is done. Your repair is done. Is that clear? Did you all understand, or did I just put a lot of effort just for no sake? Is that clear? Quick feedback. Did you all understand? कि शोल्डर रिपेयर में हमने क्या किया? तो Shouldice रिपेयर में you have looked, I'll write every single step that we have described. The step number one, I'm going to incise the external oblique aponeurosis. I'm going to incise external oblique aponeurosis. Once you incise the external oblique aponeurosis, you expose the inguinal canal. You expose the inguinal canal. Third step, you secure the cord, that is your vas deferens, and reduce the hernia. And reduce the, right? So you incise the external oblique aponeurosis. You explore the, you expose the inguinal canal, you secure the cord and reduce the hernia, right? Now, once you have done with this, the fourth step, what you're going to do, now you're going to incise the fascia transversalis. Once you incise the fascia transversalis, you have two leaflets. You have the superior leaf and the inferior leaf. You have the superior leaf of the fascia transversalis, and then you have the inferior leaflet of the fascia transversalis, right? Now, once you have done this, the step number 5 is to suture. It is to suture inferior leaf to the under surface, to the under surface of superior leaf, of the superior leaf of fascia transversalis. Once you're done with this, once you're done with this, then the sixth step is you suture superior leaf to the over surface of inferior leaf, of the inferior leaf of fascia transversalis, right? So until now, you have created, med student is done for both direct as well as indirect, right? So one you go under, that is the inferior leaf goes under the superior leaf comes on top of the inferior leaf. Together you suture it, because this is the first bilayered structure that you have created to strengthen, right? Now once you have done, the step number 7 is going to suture conjoint tendon. I hope everybody knows, no? We just learned conjoint tendon is formed by the fusion of the internal oblique and the transverse abdominis aponeurosis. That is where the conjoint tendon, it arches over the inguinal canal, all the content goes through it. Conjoint tendon is an important landmark also. Okay? So you suture the conjoint tendon to inguinal ligament, to the inguinal ligament in continuous, in the continuous, in the continuous suture. And the last step that you do is going to suture, now you suture conjoint tendon to inguinal ligament in interrupted fashion. Interrupted, right? And the last one that you have, the last one that you have is to close external oblique, to close the external oblique. Okay? And this is how you repair your hernias, and this is your Shouldice repair. I hope everybody is clear with the Shouldice repair. Okay? So this is how you put up the whole context of the repairs. Okay? So first repair is out of the way. Now understand what is a shoulder. Shouldice repair हो गया? Yeah. Done with the Shouldice repair. Now we go with Bassini. Everything remains the same. अब तो मोटा मोटा सब समझ आ गया है. ऐसा समझ ज़्यादा difficult. Now we are going to Bassini. A Bassini's repair have a lot of modifications. Tell you a standard Bassini repair. Here you need to remember that the fascia transversalis that you open now, third, the conjoint tendon also that of the clear. तो Bassini's में क्या है, fascia transversalis को भी inguinal ligament से जोड़ दिया और your conjoint tendon को inguinal ligament से तो Bassini's repair बोलते हैं. If you see our context here, so we'll come back here. Bassini's में क्या करेंगे? We have the external oblique aponeurosis, we have cut open, we have exposed. Now डाल दिया. So the conjoint tendon. Now we have opened the fascia transversalis. Again here, fascia transversalis, we open, we are going to suture it to करना आसान है. I'm taking a lot of pain to understand benefit out of it, trying my best, right? So now Bassini's में क्या किया है, fascia transversalis को कट नहीं किया है, the whole fascia transversalis to bring it down then suture it to the inguinal ligament. पहले fascia transversalis को inguinal ligament से चिपका देते हैं, that is the first. ये हमारा suture material. This is your fascia transversalis. To take the fascia transversalis, bring it to the inguinal. As we bring inguinal leg, पहला हो गया. First thing that we have done, we have sutured the transversalis to the क्या है, conjoint tendon. Conjoint tendon को फिर लेके आओ जो inguinal ligament के पास. So we brought it again. ठीक है. अभी हम make sure बना रहे हैं. सेलो टेप और चिपका दिया. तो जॉइंट टेंडन को हमने लिया. तो दिस इज योर कंजॉइंट टेंडन. द कंजॉइंट टेंडन दैट इज स्पाइनल लिगामेंट हमने लिया और जॉइंट टेंडन conjoint tendon is now sutured to spinal ligament. Now I'll close the external oblique. So now you say Bassini. Bassini is a two-layered repair. Fascia transversalis to that of the inguinal ligament, conjoint tendon to the inguinal ligament. Together it forms a nice solid base for the posterior wall. So the strength of the abdominal wall is restored. That is the whole objective of Bassini's. Clear a Bassini's? Okay. Very clear with Bassini's. Bassini's repair में you have done this only. Yeah. फिर बारी है McVay repair. What do we do in McVay repair? I am going to the fascia transversalis. Transverse ligament. Second, you joint tendon First, you now know the fascia transversalis and joint tendon. Both of them are sutured to the Cooper. Where do you have this Cooper's ligament? Take this across here. This is the iliac tubercle. From there, it is going to turn backward. Call it as. From there, it is going to act. First ligament got to tell you that there is an bachelor extension. This is the inguinal ligament. This is the lacunar ligament. This happens to different words on. So this or inguinal. This is your inguinal. This happens to was you have the inguinal ligament, have the lacunar ligament. Now in McVay repair, what are you doing? You are doing the fascia transfer. So I say the most layer that I have just shown transfer. What we do, take the fascia transfer. Then that of I'm suturing the fascia transversalis to the first ligament. At the same time, the joint, when I talk about the conjoint tendon formed by dominus, then you have the internal together when internal oblique, internal oblique is together form, together form tendon that of conjoint tendon to that of the things you have done. Number one, the fascia transversalis is similar to that of the Cooper's ligament. The conjoint tendons, joint tendon. Here you see the conjoint tendon is now being sutured to the here. This is how you do your mech. What we do. Now, one of the most complex repairs that you will going to be or uh, now Dasarda's repair, very own Indian repair. How about complex, right? We'll try to understand that how the Dasarda's repair is. I'll try to explain Dasarda's repair. Again, have a small representation for you. Same thing, external oblique aponeurosis. This happens to be your superficial inguinal ring. This peritoneum, you lift it up, you have the fascia transversalis. This is the deep inguinal ring, vast difference turning medially. This is your ilioinguinal nerve that is there, right? So Dasarda says that in order to repair it, what I'm going to do is I'm going to open up the external oblique aponeurosis. That is something which I have to do. I'm going to open. I have opened the external oblique aponeurosis. Once you have opened the external oblique aponeurosis, I'm just going. oblique upon external oblique aponeurosis, another leaf. Now everything else is same. You have the inguinal canal that is present. Transversalis. This is a deep ring. You have reduced the hernia. Now I have to create a new repair technique. What I'll do is again external oblique aponeurosis are states that you have. Upper one is called as superior, lower one is called as inferior. I will take the upper leaf and I am going to refer it to the final ligament. Take this for understanding. I'm going to take the external oblique aponeurosis upper leaflet and put it down. So to use our cell. This is the upper leaf of the external oblique aponeurosis. This is done. Now what I'll do is I will cut another strip from. You have to see here. You have sutured it here. At 2 centimeters, I'm going to cut another strip. So we are taking here. So I've sutured it here. 2 centimeters. I'm going to start cutting. The dynamic strip that it is like a tissue mesh that you're trying to create. Now you see, it was like this. I've cut open. Now this is this present. Now I'm going to take this part and bury it on the under surface. Bury it onto the under surface dynamic strip that we have created. I'm going to bury it on the. We'll just you're now taking this surface. Done. Right now, this is the lower leaflet that you've already done. No, the upper leaflet was divided. Now this lower leaflet you have already will now be sutured per leaf. Final nail in the coffin. Final coffin. Upper leaflet now sutured. Right now, your Dasarda's repair. Dasarda's repair is. So Dasarda's repair little bit complex. We'll try to understand and analyze. Dasarda says you all understand that it is going to be an external oblique. So I am just or for fish. This repair runs. This is going to be a very articulate repair. Try to give you a little bit more insight. But again, Dasarda's repair layers, if it is quite simple, but then technicality that I've just a bit complex to it. Technicality is a little bit extra upon your voice is low, battery die. Now, voice is perfect. Chalo. This is your external oblique. So what we did is in external oblique aponeurosis, Dasarda said, let's via the spinal canal. So once you open it up, you now have the upper leaf and you have the lower. Now you have two. This is the lower leaf that you have, and this, you just hold it down. This is the lower leaf, and this is your upper leaf. The two leaves that you have created. One you have created. There's an upper leaf. There's an upper leaf which is, if I just highlight it. So this is the upper leaf that you have, and this lower leaf. So this is the upper leaf. What I'll do is I will take this upper leaf and suture it to. I'll take this upper leaf and suture it to the lower leaf. Once I've sutured it, there's a new strip that you have created. So we'll just say that this is the new strip that you have created by suturing the upper leaf to the strip that you have created. This is the upper lip, which is upper leaf that is sutured to the loop of the external oblique aponeuron. So once you have sutured, so now here the upper leaf is now sutured to the inguinal ligament, which is down there. Now I'm going to incise this part. So once I'm done, I'm now going to incise. Now once I incised it, again I have created the new parts upper leaf, that is into new upper and new, right? So this new strip that you've created, again you have created upper and lower. This lower will be tucked in. So what I'll do is I'm now going to suture this lower to the undersurface. This lower to the undersurface. And this new upper that we are now created will now be sutured with the lower leaf that is present. Right? So this is what your Dasarda's repair is. This is what your Dasarda's repair is. Okay. So in the Dasarda's repair, if you want to truly understand, I've shown you the representation, just review that as well. The step number 1 is to open the external oblique aponeuron. Now once you open the external oblique aponeurosis, as you have opened, so if this is the external oblique aponeurosis, you have now created this into two components. You have the upper leaf and the lower leaf. You have now created this into components, upper leaf and the lower. So this is your upper letter. This is the lower leaflet of the external oblique aponeuron. External oblique aponeuron, right? Now under beneath here you have your inguinal ligament, right? So this is where you have the inguinal ligament. Now the step number 2 is to suture that the upper leaf of external oblique aponeurosis is sutured to inguinal. It is sutured to the inguinal ligament. You will notice that from here I will take this to the inguinal. Now once I do this, what is the end result that is going to be present? This is the upper leaf. I have dragged it down, and this upper leaf now anchored to that the inguinal ligament, and here I have put the suture. This is the upper leaf. This is your inguinal ligament. This is the inguinal ligament, and we have sutured it. Okay. This is the first part of the story that we all understand. Nothing spectacular about it. Okay, the upper leaf of the external oblique aponeurosis, I've taken it under the lower leaf, and then I have sutured this to the inguinal ligament. This is done. Where is the lower leaf? The lower leaf is still available here. So I'm going to use a different color for lower leaf. So let's say we'll keep lower leaf a bit pink. So this is the lower leaf of the external oblique aponeurosis, which is still here. So this is the upper leaf. Now what we are going to do is we are going to divide this upper leaf which was sutured again. So step number 3, I'm going to divide the sutured upper leaf again. So once I divide the upper again, this time you have created a new upper and a new. Okay? This time I've created again a new upper leaf and a new lower leaf. Okay? Now once you have done this, this is how you have. Now what I'm going to do is I'm going to lift this upper leaf up. Now as I lift this upper leaf up, this is where I have lifted the upper leaf. We'll make this is the upper leaf that we have, and I have opened this upper leaf. This is the new upper that you have created. This is the upper. So when is your new upper? I'm going to suture, or I'm going to suture the new lower to the under surface, to the under surface of the new upper. So the next thing that I'm going to do is to suture the new lower leaf to the under surface, of new upper leaf, the new upper leaf. Okay. Now once you have done this, what is the ultimate result? The ultimate result that you will see, this is the new upper that is present. This was the new lower. I use a different color. The new lower which has been sutured to the under surface. This is already sutured to that of the inguinal. So this is your new lower that was sutured to the upper leaf. You've already seen that there is this suture which is onto the upper surface. This was already sutured to that of the inguinal. We already have our old lower. This pink one is a old lower leaf. No? This is a old overleaf. This is your old lower. Now what is you have to do? All that you have to do is now take this upper and this lower closer. This is your new upper that you have created. This is your new upper that we had, and this is your old lower. LO stands for old lower. Now we're going to suture it together, right? So the last nail in the coffin that you're going to do is to suture this upper with this lower, right? So then suture new upper leaf, old of external oblique opponent. And this is how you do your Dasarda's repair. If you understand Dasarda's repair, it is one of the most complex repairs that you have. But again, it is very challenging in terms of performing technically. But then once you have achieved it, it is as good as mesh repair. It is as good as mesh, right? So this is in the context of Dasarda's repair. Lichtenstein tension mesh repair is same. Open up the external oblique aponeurosis, reduce the hernia, put a mesh there. So where do you put the mesh is, so we have the last representation for your Lichtenstein tension-free mesh repair. So again, same. This is your external oblique aponeurosis. This is your inguinal canal. This is where your, I would say, the content is coming. So what I'll do is, same. We will open up the external oblique aponeurosis. So once you open up the external oblique aponeurosis, you open the external oblique aponeurosis. After you open, you have exposed the deep inguinal ring, and our content, so the content of the inguinal canal, which is going to be a vast difference, is coming from the deep inguinal ring, right? It's coming from the deep inguinal ring. So what I'll do is I will take a mesh, right? Now you can take any mesh you want. Here is my mesh. Where did we put our mesh? Hold on for a second. Okay. So let's say this is the mesh that you have. I am going to take the mesh exactly which is required to fit into our inguinal canal. So this is the mesh that we have. This is the mesh that you have. And I'm going to put the mesh here, right? Covering the deep ring. So how do you cover the deep ring is without causing any damage to the vas difference is to cut the mesh with a small, like a fish. And you cut it like a fish. Now why this is important is when you put the mesh on the posterior wall, right? This is where you're going to put the mesh, right? So I want this cord structures to be secured. I don't want the cord structures to get damaged. So I'm going to put the mesh like this. So I'm putting a mesh so that the cord can flow through it. And then I'm going to suture the mesh onto the posterior wall and then repair the canal, right? So this is what, how you do your Lichtenstein tension-free mesh. So this was an exclusive class on all the tissue repairs and the hernioplasties that we had. We have covered a wide range and variety of the techniques: Shouldice, Bassini's, McVay, Dasarda, Lichtenstein. This is the only video that is present on the entire internet which explains you all the hernia techniques with its precision in one single video. So hope you liked it. If you had any suggestions that how could have made this more better, please write us on the comment box. I will try to improve it at the same time. But then from the not only from the postings point of view as well as a practice point of view, if you're a resident, these are steps are quite important. If you're an undergraduate, you don't need to remember everything, but just for the sake of intriguing value, you should know that what are the components. In an undergraduate exam, they'll only ask you the names, which are the tissue repairs, which is the mesh repair. If you're known and if you're aware of it, it is more than enough. Any questions, any queries, you know where to reach out. Please do write us on the following. You can write it on the Telegram group as well as the Instagram. It is by the surgery guy. It is by my name, that is your Dr. Sandeep. Any questions, any queries, please put it across here. Thank you so much for joining. We'll resume back tomorrow. And tomorrow we will talk about the other forms of hernia, right? Tomorrow we'll be talking about femoral hernias, obturator hernias, their mesh placements and everything, so that you're clear. We'll take another episode and then we'll finish the hernia component and then we'll move back to our core GIT. Until then, thank you so much for joining. Good night. Have fun.